Headache. It's probably one of the most common reasons a patient is going to walk through your door, and it's definitely one of the most feared questions on exams. So in this explainer, we're going to build a really solid clinical framework so you can tackle any headache with confidence. Let's get right into it.
So picture this. You're in your clinic, and a patient comes in and says those exact words. This is the worst headache of my life. Your heart rate probably just went up a little, right? Well, this is that classic high-stakes scenario. And by the end of this, you're going to know exactly how to handle it, calmly and competently.
All right, here's our game plan. We'll start with the absolute basics, primary versus secondary headaches. Then we'll get into the most important part, spotting the red flags. After that, we'll walk through a solid clinical approach, figure out how to tell the common headaches apart, and then we'll wrap it all up with a simple algorithm you can use on the wards and, of course, for your exams.
So when a patient comes to you with a headache, the very first question you have to answer is all about safety. Is this just a benign primary headache, or is this a symptom of something way more dangerous lurking underneath? That one distinction is going to drive your entire workup.
So what's the actual difference? Well, a primary headache is when the headache is the disease. Think about things like migraines or tension headaches. But a secondary headache, that's a symptom of something else, something like an infection, a bleed in the brain, or even a tumor. And our number one job, every single time, is to make sure we've ruled out those scary secondary causes first.
Okay, so how do we even begin to hunt for those dangerous secondary causes? Well, we use our single most important tool, a systematic search for red flags. And trust me, there's a really simple mnemonic to help you remember all of them.
Meet SNOOP. This is your safety net. Seriously, commit this to memory. It's a simple framework that helps you systematically screen for any warning signs of a serious problem. Let's break it down, letter by letter. First up, S stands for systemic symptoms. So you're asking, does your patient have a fever, chills, drenching night sweats? Have they lost a bunch of weight without even trying? Or, really importantly, do they have a history of cancer or an immunocompromised state like HIV? Any of these should make you start thinking about infection or maybe even a malignancy.
Next is N for neurologic symptoms. Is the patient confused or just not themselves? Do they have any new weakness or numbness, maybe just on one side? Has there been a seizure? And then on your exam, are you seeing papilledema? That's the swelling of the optic disc you see with high pressure. Or do they have a stiff neck? These are all major red flags that point to a problem inside the skull.
Now, O is for onset, and listen, this one is absolutely critical. A headache that goes from 0 to a 10 out of 10 in under a minute, what we call a thunderclap headache, is a medical emergency. You have to immediately think about a subarachnoid hemorrhage. The second O stands for older age. A brand new headache in someone over the age of 50 is a red flag until you can prove it's not. We just have to be more worried about things that are more common in this age group, like giant cell arteritis or, again, tumors.
And finally, P is for pattern change. This is really for patients who already have a known history of headaches. If they tell you this one is getting progressively worse or that it just feels completely different from their usual ones, that's a big concern. And also, you want to be alert for headaches that are brought on by things like coughing or straining, or ones that get a lot worse or better depending on if they're standing up or lying down.
Okay, so with the SNOOP mnemonic in your back pocket, let's talk about the actual assessment. I want you to think of yourself as a detective here. The patient has all the clues, you just need to know the right questions to ask and the right signs to look for.
I can't say this enough. A detailed history is, without a doubt, your single most powerful diagnostic tool. You need to dig into the timing, the character of the pain, any associated symptoms like nausea or sensitivity to light, potential triggers, and super importantly, ask how often they're using pain medications. Honestly, the history will give you the diagnosis more often than any scan.
Your physical exam should be focused and efficient. You don't need to do everything under the sun. Always check the blood pressure. Do a quick screening neuro exam. And make sure you take a look at the optic discs with a fundoscope. For any patient over 50, you need to feel the temporal arteries. And of course, check for any signs of neck stiffness.
So, let's say you've gone through your SNOOP screen and no red flags. Your history and exam feel reassuring. Great. Now we can confidently shift our focus to diagnosing the primary headache. It's time to meet the usual suspects.
This table really breaks down the classic personalities of the big three. Notice the differences. Your migraine patient probably wants to go lie down in a dark, quiet room because the pulsating pain, the light, and the sound are just too much. Contrast that with a tension-type headache.
That patient might describe it as a tight band around their head, but they can often still function and go to work. And then you have cluster headaches. They are a completely different beast. The pain is excruciating, sharp, usually behind one eye, and patients are often agitated, pacing around. You'll even see physical signs on that side of the face, like a red, watery eye or a runny nose.
Okay, before we wrap this up, I want to circle back one more time to the really dangerous secondary causes. These are the diagnoses you absolutely, positively cannot afford to miss. Let's just quickly review the classic presentations of our most wanted list.
Subarachnoid hemorrhage. The keywords here are thunderclap onset and worst headache of life. If a patient says that, this has to be at the very top of your list. You'll want to check for neck stiffness or meningism, which is caused by blood irritating the lining of the brain. This is a true emergency, and that patient needs to go to the ER for a CT scan right away.
Giant cell arteritis. Your patient is over 50 with a new headache. They might tell you it hurts their jaw to chew, that's jaw claudication, or that their scalp is tender when they brush their hair. On exam, you've got to feel for a tender or non-pulsatile temporal artery. Getting this diagnosis right and starting steroids quickly is absolutely crucial to prevent permanent vision loss.
Meningitis. Here you're looking for that classic triad: headache, fever, and photophobia. That's when light is physically painful to look at. The key finding on your exam is going to be neck stiffness, or what we call positive Koenig's and Brzezinski signs. This is another one that requires immediate action.
And finally, raised intracranial pressure. The classic story here is a headache that's worse in the morning or when they do anything that increases pressure, like coughing or straining. It's also often associated with vomiting. The key finding that you have to look for is papilledema, that swelling of the optic nerve when you do your fundoscopy.
Whew, okay, we've covered a lot of ground. We've gone from spotting red flags all the way to telling the subtle differences between primary headaches. Now let's bring it all home and consolidate everything into one practical gameplay.
This algorithm right here puts everything we've talked about into one clear pathway. Let's just walk through it. Every patient starts at the top with that detailed history and exam. Then you hit your first, most critical decision point, screening for red flags with SNOOP. If you find any, if the answer is yes, you follow the path to the right and you start your workup for a secondary cause. If there are no red flags, a no, then you can safely proceed down the left path to figure out which primary headache it is, branching out to migraine, tension type, or cluster. This is your roadmap. Use it every single time. So, let's get down to it. If you remember nothing else, remember these pearls. 1. SNOOP first, always, to rule out danger. 2. Your history is king. It's your most powerful tool. 3. A new headache in anyone over 50 means you have to think about GCA. 4. Worst headache of life should make you immediately think subarachnoid hemorrhage. And 5. Always ask how often they're taking pain meds to screen for medication overuse headache.
Look, making the right diagnosis is a huge and vital first step, but the work doesn't stop there. In fact, the real art of medicine is just beginning. So I'll leave you with this to think about. How do you move beyond just giving the headache a name and actually partner with your patient to create a plan that gives them their life back? That's the next chapter.